and again, we talked about this, the whole implementation around effective EHR, and we'll talk more about this EHR implementation next week. But, it's absolutely the scaling of computer power and storage, the reduction of expense, and widespread broadband definitely have that in there. One of the things that I also noted was, especially back in the early to mid 90s, was that there was a lot of reticence among clinicians in adopting technology, not just physicians, but also nurses, pharmacists, lab techs, radiology, whomever. People were reticent to accept this new technology. Generation of the clinician, or the age of the clinician, also plays into the amount of patience that you have with technology. So in addition to the electronic and physical requirements, in addition to the internet or the broadband requirements, is also the organizational change requirements, and also the capacity of the clinicians to adopt change. So those are kind of the 5 that I really kind of look at when I talk about effective EHR implementation, is that you have to have the computer power, you have to have the hardware, you have to have the clinicians willing to accept and to change, and the ability to interact with that technology. So those are all the things that are important with that. And finally, the electronic health record system and how it affects patient care. Obviously, it can reduce a number of the medication errors, improve safety through that e-prescribing, through clinical decision support systems. It improves efficiency in healthcare. Not only do we have the information sharing and cost savings, but we also have a reduction in certain errors, such as duplicate lab errors, or duplicate lab orders, or duplicate radiology orders. I remember the time when a phlebotomist would come up, and then 6 hours later somebody else would come up and take blood, and the patient's like, why are they taking blood multiple times? Well, the system didn't catch that the order had been placed twice, or there was a tick where the order got placed once but showed up twice in the system. But we didn't have the controls in place to be able to prevent that from happening. So you're seeing that the care that patients are receiving is more efficient, that there's less duplication of orders, and that there is certainly a cost savings involved with that as well for the provider. Information sharing, obviously that is an impact on quality, as providers and different providers can provide and access the data and really coordinate the care for the patient with their fellow clinicians. And of course, the patient satisfaction we already mentioned, but wait times for scheduling, improved communication, and certainly turnaround times for inquiries and billing. Hopefully there's an improvement in the quality of the billing, so that the billing is more accurate and there's less duplication of charges. Of course, there are it's the access of patients to their own records, the PHR, and reducing the need to provide the same information repeatedly to providers. Hopefully, once you walk into a system and you're able to provide the information, when you go into that same system for a test or for a follow-up, you don't need to provide all the information again, and certainly not on paper with pen and paper. And actually, that's still something that's an issue today, going in and providing that information. So hopefully that's something that will become a thing of the past as we move forward over the next 5 to 10 years. Outcomes. Certainly the effect of patient safety and efficiency of care and utilization of care models are patient outcomes. And because the providers have access to evidence-based protocols, these clinical protocols, order sets, care plans, because they have access to this, it's not just has your physician or clinician gotten up to date on their information, it's almost forced upon them because of the fact that the evidence-based practice is updated even without the physician or the nurses or clinician actively taking care of that. Cost savings, we talked about the reduction of duplicate tests, clinical workflows, reduction in the patient care errors, and of course, this is going to lead to a lower cost of care with the savings passed on to the customer. Now, the customer is not necessarily the patient. The customer in this situation is anybody who's actually paying the bill, and that would be private insurance as well as the government. Private pays a very small portion of the mix of the revenue mix for a hospital or for an organization. So when we're talking about saving some of this cost, there certainly should be some savings that go on for the government as well as for insurance companies. So just as a reminder, please review this lecture and the assigned articles and to-dos. Please complete the assignments and discussion by the due date.